I realise that people are still coming into the room, and it's fantastic to see so many of you here. There are seats at the front, so if people do want to come down and sit at the front, I promise we won't bite or perhaps shock. You're more than welcome. So my name's Tom Johnson. It is a great pleasure to join you for lunch today. This session entitled Cracking Open the Discussion on the Clinical Experience with Intravascular Lithotripsy in Acute Coronary Syndrome. And this very much exemplifies the fact that until now, actually, the use of shockwave in ACS in Europe had been off the IFU, but now is actually something that is within the mandate of the device. These are my conflicts. So the objectives of this afternoon are to understand the best strategies to safely deal with calcium in the context of acute coronary syndrome, to share clinical experience, to uncover practical tips and techniques for the use of IVL in complex calcified lesions, and then hopefully to gain some further insights from the latest real-world intravascular lithotripsy registries and data. We've obviously just had a session this morning with some really exciting data from Benjamin, with Calypso, with Nicola, his co-PI, from Rollercoaster with Alfonso, and hopefully we'll hear some more about that data here. And we do have a fantastic panel, so I'm delighted to be co-chairing this with Mervat, who is our spokesperson for the session. We have Alfonso, who will come up next, Benjamin Honton from Toulouse, Jonathan Hinton, a colleague from Bournemouth in the UK. And so with that, we'll, I hope, proceed to Alfonso's presentation. But please do make this as interactive as you can. You have the ability to interact through the app, so you can post questions, post comments, and we'll do our very best to answer those in the hour that we have.
Thanks for your introduction. Thanks for being here at this hour. I'm going to talk about the potential advantages of IVL in ACS, in acute coronary syndrome. These are my conflicts of interest, and I'm going to divide this 10 minutes session in three parts: the theoretical advantages of IVL in ACS, then a clinical case to show them, and then some evidence about IVL in this setting. So which are the potential advantages? We know we have different plaque modification techniques. All of them are complementary, but they have some limitations. Regarding high pressure balloons, you know when you have an eccentric plaque or nodule, the balloon is going to expand away from the plaque. If you increase the pressures, you can break the vessel, mainly in the shoulders of the plaque, and it's rare that you can modify deep or very thick calcified plaques with these devices. Atherectomy is also a very useful tool that we have used for decades, but has a steep learning curve, is contact dependent, is unable to modify deep calcium. It causes thermal injury and can lead to more thrombus burden. It's unable to protect side branch. Sometimes in tortuous vessels, you can have a risk of dissection, of perforation, and you have distal embolization and slow flow, as you know. Lithotripsy can solve some of these disadvantages because it's an easy technique with no requirement on a specific wire. You can protect the side branches. You selectively disrupt calcium, even deep or thick calcium. And this calcium disrupted does not go anywhere, so you are not going to have slow or no flow. And all of this without going up, very up with your atmospheres. So it's quite safe. And it's a very easy technique. And has proven results in different types of calcified lesions. Regarding specifically acute coronary syndrome, we are in a higher thrombus burden setting, and we obviously don't want to increase this thrombus risk, and we don't want to remove this thrombus and push it to the microcirculation with a atherectomy device. Second, we are in a higher bleeding risk scenario because the patient profile of the patients, and also because we are using more potent antithrombotic drugs. So it could be more difficult dealing with perforation, so we need the safest technique in this setting. Third, some of these patients with ACS come with ventricular dysfunction, heart failure, as we saw in the replica trial, and arrhythmias. So probably we need to choose the plaque modification technique which is best tolerated for the patient. And finally, sometimes in some acute coronary syndromes we need a fast revascularization, especially in STMI, and we need to simplify PCI. And if you have a dilatable lesion in a LAD with calcium and thrombus, 2 a.m. in the morning, your nurse is going to ask, what is your next move? And probably your next move should be the easiest technique that is also effective and safe. So I am going to show you a clinical case that came, again, Saturday night. 82-year-old male without comorbidities who complained for resting angina and transient ST segment elevation in anterolateral leads. He underwent an emergent coronary angio, but in the ambulance suffered an episode of ventricular fibrillation that was successfully cardioverted. The ejection fraction was 42% with anterolateral hypokinesia, and when he arrived at the cath lab, he was asymptomatic and stable. This was the first angio in the right. As you can see here, he had a severe calcified restenosis in the ostium of the vessel, and also these lesions in the left with severe critical calcified lesions in ostium of LAD and also the circ. In addition, he had a chronic total occlusion in the mid-left anterior descending filled through collaterals from this big diagonal branch. As the patient was asymptomatic and stable, Saturday night we decided to stop, send the patient to the ACCU, and committed in the heart team on Monday morning. Of course, he was rejected by surgery, and we proceed to the procedure the same morning, in the Monday. So, left main bifurcation, critical stenosis in the circ. We need a wire there, not to lose it. Severe calcification, probably thrombus because it's acute setting, and the left ventricular ejection fraction 42, ostial right coronary artery disease. So we decided to assist the PCI with ECMO, do the plaque modification technique with shockwave, and protect the side branch. We implanted the ECMO. We crossed 2 wires to the LAD, to the diagonal, and to the circ with some difficulties in the circ. We dilate with small balloons, and then we try to advance the IVUS. The IVUS couldn't cross distally, but we observed this image in the proximal LAD that support our strategy. We use IVL, 3.5 balloon, 60 pulses in the left main LAD. We dilate with good expansion the circ, and we use drug-eluting balloon at this position. Afterwards, we went for the occlusion. We could cross, we could dilate, and we complete the lithotripsy procedure in the proximal mid-LAD, proximally to the diagonal branch. After that, we did IVUS. We decided to change our initial strategy and make a culotte in the bifurcation with the diagonal, and then implanting a stent in the left main to the LAD with this good expansion that you are seeing, doing POT and all the things you already know. We confirmed the result with IVUS, very good expansion, as you can see here, in all the segments of the lesion. So this is a real complex and also high-risk patients in which a complication could be fatal. And you have also bifurcation with a critical stenosis at the ostium of the side branch. Probably in this setting, lithotripsy makes sense. It could be the safest option, predictable, and with the possibility of protect the side branch. Evidence of IVL in ACS. We know that the evidence of IVL has been made in stable patients. In these patients, it is safe, it's effective. However, real patients are not like that. I know like patients in the root cut trial. And we see that are more complex. Some of them, up to 48%, come with acute coronary syndromes and have a higher MACE rate. We have seen it recently in the CAT PCI cohort, comparing the post-approval study patient, the PAS patient, 6% similar to the root cut trial, and the non-PAS patients that are similar to real-life patients. These patients came 36% with an acute coronary syndrome. And when we extract data from the replica trial from Oriol Rodriguez-Leor, we see that the angiographic success is similar when comparing patients with acute coronary syndrome and chronic coronary syndromes using IVL. However, the MACE rate at 30 days is different. It's higher in ACS patients, logically, because they have a higher risk profile. And even we have in other data, they have a higher in-hospital mortality compared with stable patients. But this mortality is in line with the predicted mortality rates. Some data from roller coaster that we have presented 10 minutes ago is a randomized trial comparing rotational atherectomy, lithotripsy, or laser in severely calcified lesions. The main endpoint is stent expansion by OCT. We included stable patients or non-STEMI patients. We excluded the culprit lesion of STEMI. We included 171 patients, 65% stable, 35 acute coronary syndromes, and there were no differences regarding baseline features between the three arms and between stable disease or acute coronary syndromes. Male 77%, 70 years old, 50% of diabetic, normal ejection fraction. There were no significant differences between the three arms, nor in between the acute coronary syndromes or chronic disease. And this is the picture of the study. LAD 71%, 82% of angiographic severe calcification by the central core lab, and these are the data of the OCT. Bifurcation, 42% of cases. The procedures were performed by radial approach in the majority of cases. The settings were left to the operators, and there were no significant differences in the procedural data. However, ACS procedures were longer with more contrast volume. Regarding the success, were similar, the device success, angiographic procedural, clinical success, similar between the patients with ACS and chronic total occlusion or chronic coronary disease, and the stent expansion and MSA was also similar. We did not observe significant differences between the three arms in general regarding complications. They were quite low, but as you can see here, there was 0 complications in the arm of lithotripsy. 0 perforation, 0 lateral vessel closure, 0 stent thrombosis. So it's the same that I said before. It's the safest, probably the safest option if you can do that. So as a conclusion, 30 to 50% of patients in which we use IVL came with ACS, acute coronary syndrome. These patients have a higher risk than stable coronary artery disease, higher thrombotic risk, bleeding risk, heart failure. They have similar procedural success rate, MSA and stent expansion, but higher MACE during follow-up because they are worse patients. And IVL has potential advantages in this setting because it's safe, it's effective, and easy to use. Thank you for your attention.
Alfonso, thank you. That was a fantastic both overview of the challenge perhaps we have with ACS versus stable patients, but then also a consideration around both the devices we have, but now some compelling data to support the use of IVL. We really do want you to interact, and so please, there are microphones in the room if you want to stand and ask a question, but equally do post comments in the chat. Whilst we wait for some comments, could I just ask you, you showed a highly complex case, and one that maybe many of us in the room don't have the capability to undertake. I'm not in an ECMO centre, and so equally LV support is a potential challenge for many people. Do you think your approach to treating calcium in ACS is different to the treatment in a stable patient? So you mentioned thrombus issues of time, speed. So does that mean you're going to use IVL differently to the way you might in another case?
So. We have no data about that, but probably it's different because if you are in a thrombotic scenario, you don't want to use rota, orbital, and this stuff. Probably laser is an option, but you know that with lithotripsy, everyone is happy because it's easy to use. And if you are 2 a.m. in the morning, your nurse is going to be happy, and you're going to be happy as well. So if you can use it, because obviously you have a percentage of uncrossable lesions as well, I think is the safest option, and is my first option in a severe calcified lesion in ACS.
Okay. Just to extend that, so I noticed in the case that you shared with us, you use 40 pulses in that proximal segment of the LAD. And
60, I think.
And it looked like from the roller coaster data, the average pulses used was in the order of 50 to 60 pulses. So I wonder, now we have a device that can deliver 120 pulses. It's not your standard to just deliver all pulses to the vessel before you finish?
It's a very good question. It's a time of price, and if I spend I take the balloon out, I think I have to take all the advantage of the balloon using all the pulses. However, in this case, I started with the left main, and I thought I needed the shockwave in the LAD. And I always left 20 pulses at least, just in case the stent is underexpanded. So I try to use all the pulses, but taking all in mind.
Okay. And any difference of Benjamin? I know you're going to share some data with us, kind of extending that, but what's your...
Yeah, we'll share a few information about optimal number of pulses. It's an opening question again, but it seemed that in the France Lily registry that it was a powerful predictors of target vessel failure at 30 days. If you do less than 80 pulses embedded in the catheter, then raise a higher number of pulses. So it's something that I find it very interesting to keep 20 pulses in case of sub-expansion of the stent. However, in our practice, we try to deliver all the pulses actually at the target lesion.
Jonathan, any difference of practice in Bournemouth?
Yeah, I think I agree with what Benjamin said. Certainly following the France Lily registry, I've been very much trying to use as many pulses as I can. Of course, trying to balance that with the number of balloons you're using. We're in a resource-scarce environment, so yeah, trying to use as many pulses as possible.
Mervat?
As many pulses as possible, and then image-guided. So if we've had adequate fracturing, then I'm happy to stop. If not, then reconsider more.
Good. I think the imaging, the idea that you image and then you repeat the imaging to ensure that you've demonstrated change is an important one, isn't it? We have a comment.
So yes, we have a question about any concern in acute coronary syndromes using shockwave with patients who may have tachyarrhythmias and they're more prone to arrhythmias. Any danger with shockwave?
I don't think so. I think that the colleague is mentioned the shock topics and this stuff. Of course, you have to consider the overall situation of the patient. In this case, we use ECMO because we're going to inflate the balloon in the left main with an ostial right disease. But in terms of arrhythmias, I think there is no concern about that using IVL, my opinion.
And I guess particularly in the setting of acute coronary syndrome, it's highly likely the patient may have defibrillator pads on, but it's not a necessity by any means. We have a question? Yes. Great.
Hi. Good afternoon, everyone. I had a query. Like when you initially said, I mean, these kind of complex anatomy we would get, and all of us are not as skilled as the panel to perform such complex PCIs. So would it be a reasonably safe option if you have some flow distally to leave it at that and then get the patient back subsequently to perform complex PCIs, including use of IVL? If patient presents to you with ACS as a STEMI.
I haven't heard anything.
So your comment is would it be safe to bring the patient back for a deferred procedure,
Yeah,
which is actually
as a staged procedure.
Yeah, which is actually what Alfonso presented, that it was the middle of the night that the images were taken, but actually due to that complexity, if I'm well understood, you sensibly came back.
You are obliged to continue because the patient is with chest pain or unstable, but if the patient is asymptomatic and unstable, I think the best way to do it is defer the patient. Monday morning, everyone there in the cath lab is safest.
Yeah, thank you.
But I think it's a really important educational point there, is that there's that need or desire to get on and do the case. But actually, when you're dealing with such complex disease and in the setting where a patient's symptoms have resolved and is now stable, semi-stable, actually to wait and have colleagues available and a full team and the ability then to, undertake the procedure as safely as possible is critically important. So we have Ritesh just asking then, so the pecking order for ACS in terms of modification, are we right to think then it's shockwave number 1, rotational atherectomy, orbital atherectomy, laser? Which way do we put that in the pecking order? Before we answer that, have a think. I was waiting for you to finish eating before sticking your hands up so we don't get baguettes going all over the place. Hands up for those people who have IVL in their cath labs. Okay. And how about those with rotational atherectomy? So a very similar number. Orbital, CSI, okay, fewer. And how about laser? 2, 3, 4, including Jonathan and Alfonso. Okay, so really most people are in a situation where they have at least IVL and rotational atherectomy to choose between. So I guess we only have to do a pecking order of 1 and 2. But so where are you going to put them?
I think for me, the safety data, and you worry about the thrombotic burden in ACS. So for me, IVL's got to be the first one. Of course, if they're non-crossable lesions, or in some circumstances where there's very heavy burden of thrombus, particularly stent thrombosis, that might be the point that I'd reach for laser. But I think for me, IVL would be the option of choice.
I'm sure that the panel will probably agree. But so just to maybe finish up in terms of the data that you've provided for us. So historically, I mean, IVL is clearly a very safe technology. It's a low pressure inflation. It's, as you showed, really no learning curve in terms of the delivery. But your most recent data looking at multiple modalities of calcium modification showed hazard related to all devices, really representing the complexity of the patients that we're treating. But there were perforations and things with rotational atherectomy, but it was, what were the hazards that were observed with IVL? So what is it that we should be trying to avoid?
In the roller coaster trial, you mean?
Yeah.
In the roller coaster trial, the only specific complication we had was a side branch occlusion in a bifurcation with a diagonal that was resolved with a second stent. But we didn't have any severe complication regarding perforations, slow flow, thrombosis, or this stuff. So in this setting, we don't have big numbers in acute coronary syndrome. This is the truth. But we did not observe significant differences between them.
Okay. Great. Thank you. So please keep the questions coming in. And it's a great pleasure to invite Benjamin up to give us now a French perspective on the current use of IVL and ACS. Benjamin.
Thank you so much for this really kind invitation, and I will share with you some about the case that we include in the France Lily registry, and this was a case of a miss of a 60 years old woman who was referred for an acute coronary syndrome related to a complex mid-LAD lesion, and so she was addressed at the Clinique Pasteur for the PCI. So the past history, she has a previous cardiomyopathic ischemia because she underwent a PCR on the first marginal, but you can see that there is also PAD, she's cupped, and she's typically this kind of tiny woman, smokers, with a low body weight, hypertension, as you can find in your daily cath lab. And we are always precautionous with this kind of presentation. No abnormality on the lab, despite, of course, the augmentation of the troponin. And I share with you the lesion, and it's obvious it's a complex lesion. It's massively calcified. It's very tortuous. And so far, we go, first of all, on the strategy of debulking with a burr of 1.5. And at this level, we have the feeling that we will go to a complication. On the acoustic sound of the burr, on the behavior of the burr, and you can see that we are losing, we are going not straight on the artery, and we have the feeling that if we insist, we go to a perforation. So what did I learn at this point? I dive into the literature, and we mentioned it, Tom. We'll try to compare. Of course, there is not a direct comparison, but if you take the complication of the different study, you can appreciate that in the CAT study, severe dissection or perforation are 0.3. And when we dive into the pre-Parcalc and Rotaxus, which are the historic trial with atherectomy, rotational atherectomy, we are tenfold higher of perforation. So that's the first point. Second point, and I think it's very interesting, if we dive into gender complication on rotational atherectomy, there is much more complication when you perform an atherectomy, rotational atherectomy in women than in men. And that is a very important finding. There is much more complication and severe complication. And Shockwave have understand that, and so Alexandra Lansky have made a pool analysis on the CAD studies, gender-related, and they find that there are no difference in terms of complication between male and female when you use IVL. And so far, they go forward, and actually, I share with you that there is an Empower CAD trial, which is a dedicated trial for the women who are actually ongoing, only women included in this trial. And so this is the first perspective that I want to share with you. I go with a rotational atherectomy in this tiny, gentle lady, and I have the feeling that I'll go with complication, and science is on this way. And so I turn back. changed my strategy, and I used a catheter extension to go with the C2 plus balloon, and it's the magic of lithotripsy. You have released the footprint. It's amazing. And we all have the lithotripsy in our CAD lab, and we see how it is effective and safe. And I use after a non-compliant balloon to be sure that this lesion is well prepared, but also to go for the tight. Okay, but also for this kind of anchoring for the catheter progression, which is I think something that we use in complex lesion, and to also go after for the protected position of the stent. You can advance the stent, and it's something that I want to share with you. It's the behavior of the stent when you release the stent from the guiding extension. You can see the stent sometimes which is diving in the distally of the artery, and something it can be tricky because you can stock after the stent in the calcification. So my advice is to also protect the position of the stent with the anchoring. And here the final results, which is acceptable in this kind of lesion. So what did I learn from this case? This case of complex teeny woman with massively and complex tortuosity was included in the France Lily National Multicentric Registry, which is a registry of all-comers patients using IVL. So we plan to, we included 500 patients with a clinical 2 months follow-up, and there is a very large criteria inclusion because all comers was included, but there is an adjudication independent committee. And we present on Tuesday the primary endpoint, which was a composite endpoint of cardiac death, all MI and TVR. And you can appreciate that at 12 months, the rate of TVR is quite low in this kind of complex population, 9.6%. And when we go on the difference of the TVF, and you can appreciate that there is 2.6 cardiac deaths at 1 month, at 1 year, sorry. There is a quite low rate of myocardial infarction, and there is only 5.6 of TVR driving by 4.4 or TLR. We talk about it, Tom, when we make the multivariate analysis of the prognostic factors coming to TVF. I mean, you can see that the complexity of the arterial disease, PAD, multivessel disease, or more than one lesion treated by IVL is an independent factor of TVF. But also, as we mentioned, the number of pulses. If you do less than 80 pulses, you have more TVF than if you do 80 pulses or more. And I think it's an important finding because we find it at 30 days, but it seems robust for the analysis at 12 months. So it's a brick on the wall to the pending question, how much do I have to make pulses on the target lesion? It's only one study to be confirmed, but it's good signal. And in this overall population, we have included 134 acute coronary syndrome. You have on red the difference between the chronic coronary syndrome. There is more multivessel disease. And interestingly, there is more predilatation and more post-dilatation in the acute coronary syndrome subgroup, which is a finding that we can discuss after. And also, there is the same number of rotatripsy, and Alfonso is a pioneer of this strategy. There is no more complication on procedural complication when you compare chronic coronary syndrome and acute coronary syndrome in the France Lily. And also, there is not difference in terms of 12-month events between the two cohorts. There is a trend. There is a trend or more target vessel failure on the acute coronary syndrome, but this is not significant. And probably we have to follow up a little bit longer this patient because we have the feeling that the trend is more on the end of the year and the curve are separately at the end. So maybe with a longer follow-up, we will see that there is a difference between the two populations. And finally, we compare the NSTEMI and unstable angina to the STEMI, which are totally two different populations. And again, there is no difference in terms of TVF, but we are dealing with a low population of STEMI. And I think it's something we have to take into account. This is not the same population. So if I must conclude, we all challenge IVL in daily practice. And it's very far from the CAT study development criterion inclusion. We are in a different population. And it seems to appear, again, effective and safe, even in STEMI, but again, with limited data. And I'm very thankful to Shockwave to give us interesting gently lady data we are coming because it's a specific population. Thank you for your
Gently
attention.
ladies. So gently lady, what do you make of that? Mervat?
So I'm going to start with some of the questions that are coming in from our audience. So one of them was the France Lilly series included about 30% with ACS and overall significant increase in non-invasively measured IMR. So have you observed slow flow and no reflow in these patients with ACS specifically?
Now, interestingly, there is no difference in terms of periprocedural complication. However, we have to keeping in mind that maybe the acute coronary syndrome subgroup is quite heterogeneous. Because I'm not convinced that end-STEMI population is the same as STEMI. We know that from the literature. And maybe it will be interesting to see with larger cohort in the case of STEMI if we have more slow flow or complication. Actually, it's too soon to tell.
Just to extend the findings you've given us, which are really intriguing. Obviously, in previous years, the French have been criticised for not using a huge amount of imaging. You didn't report your imaging rates for this registry. How much was imaging used?
You are eagle-eyed, Tom. Yeah, there's lack of data of imaging in France for sure. It was 20% of the procedure, which is not so bad in France, but in the UK and so far with our Asian colleagues, it's very low. So I think we have to increase, and we have to, in the future, I hope, because we are leading the France Lilly Plus, which has 500 patients more, and I expect that the rate of imaging will increase. However, there is a problem of reimbursement of imaging in France.
But imaging didn't play out in terms of the multivariate analysis. No. That's a shame.
Yeah, that's a shame. Yeah, for sure.
Okay, but I mean that is an interesting one. I think you sound apologetic, but the reality is that 20% reflects probably the majority of people's experience globally. And to say the UK is better actually is misleading. The UK data for imaging is 25% overall. I think interestingly, though, calcium has become a subset where imaging is used much more aggressively. Certainly in our practice in Bristol, with the arrival of IVL years ago, it resulted in us shifting almost to 100% imaging, 80, 90%. I mean, Jonathan, I know Bournemouth has always been a high-value tech operator.
Yeah, certainly we like our technology, but I think you do get additional information from intracoronary imaging, and of course we all work in different healthcare systems where availability is challenging, but I find it helpful.
If I can jump on this comment, we performed with Nicolas the Calypso trial, which was a randomized trial between angiogram and OCT guided in calcified lesion, but more on the OCT, we perform an algorithm of decision according to the calcium arc. And very interestingly, we have seen that in the OCT decision, IVL was the first decision of the operators according to the OCT data, whereas on the angiographic, non-compliant balloon was the first one. So you are absolutely right. We have the feeling that in the subset of calcified lesion, the role of intracoronary imaging is major, the place of IVL is major, and it's something we have to increase in our daily practice.
I think perhaps the only thing I would add is that actually in the setting of an acute coronary syndrome, particularly in the setting of STEMI, where we want to be minimalistic, intracoronary imaging is actually valuable because that will tell you that you may be safe with just high pressure balloons or no modification. So I know the hesitancy in practice in ACS. So another question that actually did come up from our followers on the platform is how often after IVL do you need further treatment preparation, lesion preparation, meaning high pressure ballooning, meaning maybe drug-coated balloons and so on, or would you safely just go ahead and stent post-IVL?
In the French registry, post-dilatation after IVL was only 64% in the overall cohort, so it's quite low. And rotatripsy was nearly 10 to 12%, and interestingly, it was always the sequences, atherectomy and then IVL, and very few IVL and then atherectomy, so that's the point. And very high pressure balloon is not common in France. It's not something that we use for the plaque preparation. It's quite unusual, more than post-stent under expansion, but not in the preparation of the plaque, so very low.
I mean, you're sharing some really interesting data. I think before we move on to the next presentation, for me, there are certainly two further things I'd like to pick out if we can. One, you acknowledged in-stent restenosis is actually quite a frequent reason for needing to pursue IVL, up to almost 20%. But then the other thing that you hit, which I think was the most important educational message, was the risk associated with female presentation. So how do we counter that, if we address that one first, if we can, in terms of acknowledging that our female patients are going to be at higher risk of complication in the procedures that we do?
Have you seen in France Lily, it's like the other registry, the women are underrepresented. It's a male registry, 80% of the cohorts. And so the Empower CAD, which will be dedicated, I think Empower CAD, it's more than 400 women patients. So it will give very insightful information about the gender risk and IVL use in this population.
Do you see similar things in Saudi Arabia?
We do, and I think IVL has offered us, we do see higher complication rate in women. They tend to be older, hypertensive, and so a higher complication rate of atherectomy. So IVL has made our life easier, provided you can actually cross the lesion. Otherwise, you're forced to use some kind of atherectomy.
And then just lastly, in terms of the in-stent restenosis, do you see in-stent restenosis offering greater challenge than a standard calcium case? We've seen a case this morning in the main arena with Nieves Gonzalo, beautiful demonstration of OCT, demonstrating neoatherosclerosis with calcium intrastent and then the use of IVL to overcome that. But how do you go about managing the in-stent restenosis presentation?
Yeah, you're absolutely right. I think the purpose of the in-stent restenosis is critical. And calcified neoatherosclerosis is, I think, is a good option. Is a good option for IVL. In terms of device success and procedural success, we don't see any difference between de novo lesion and in-stent restenosis in the France registry. But I think to be sure that the etiology of the under expansion can be related to calcification is critical.
Okay, fantastic. Thank you. So. It gives me great pleasure to invite a colleague from outside Europe to join us. Jonathan, it's hurting me a lot, yeah. I'd be delighted to hear about the Bournemouth and UK experience.
Thanks, Tom. I'm not quite sure what to think of that introduction, but yes, rather sad. But yes, thank you for the introduction, and thanks to the organising committee for giving us the opportunity to share a case and some of our data that we've been collecting. I have the usual sort of declarations. So it's 6 a.m. in the morning. It's been a busy night. You've been up most of it, and as is often the way, there's another case coming, and it's a 74-year-old man who presents with an anterior STEMI. And as you can see, his LED is occluded, but if you look more closely, you can see heavy calcification burden in the proximal LED. So we already know that this might not be so straightforward, but we open it up in a standard fashion, nothing particularly unusual there. And as we've been discussing, we like to image, even though it's 6 in the morning and we're busy. I think it adds something. So we went on and performed IVUS. And as you can see, we can see a good landing zone, except there's lots of distal disease, but a good landing zone there. And then a degree of eccentric calcification, and then more circumferential calcification. And then proximally, we have a tighter lesion with probably heavier calcification, and then a reasonable landing zone proximally. So just to highlight the area of concern, really that proximal lesion where you've got concentric calcification without much reverberation. So it's 6 a.m. after a busy night, what would you do? Well, rightly or wrongly, we decided that we would try with NC balloons and angiosculpt. This is quite a nice image, stent boost showing the calcification wrapping around the angiosculpt. And I guess in hindsight, probably unsurprisingly, we were unsuccessful in dilating this lesion. So of course, then we think about IVL. And as we've already discussed, the ability to get it out quickly after a long night with a small team is brilliant. So, you can see here the timing. So that scoring balloon, 6:09, and then we've already got lithotripsy out and commenced within 6 minutes. So one of the real advantages, I think. So as you can see, the first image, under expansion of the shockwave balloon, we deliver all 120 pulses and get better expansion. And then we go on and re-image to understand what difference we've made. Now, of course, this isn't the high-definition IVUS, but you can already see fractures in the calcium, which are very encouraging. And then if we look at that area of most concern, we can again see 2 nice fractures, suggesting that we're going to get good expansion. Now, as we've already discussed, whether you take an NC balloon or not at this stage, I think it is open for discussion, but we did. We got good expansion and then went on and finished with a biofreedom stent. And actually, when you look at the clear stent when we're post-dilating, you can see the calcium wrapping around the stent architecture and then finishing the top with a 4.0 NC. And because we're Bournemouth and we think it's really important to be part of studies and recruits, then this gentleman kindly participated in the E-Ultra registry. So we're quite happy with the final angiographic result. I accept there's lots of diffuse distal disease, but I think we felt that was best managed medically. But we're not quite done yet. We wanted to go on and look at the IVUS result. So these are very short runs. As you can see, the distal landing looks acceptable. And then this is the run in that sort of proximal LED where we had that the tightest area of calcification. And you can see eccentric expansion, but the MSA here is 6.9. So we're quite happy with that. And then the landing in the proximal LED is also good. So I thought we'd share a little bit of the data that we've been collecting around the C2 Plus balloon. We were fortunate enough to be part of the early adopters in the UK. And the advantage, of course, is that it has 120 pulses as opposed to 80. It feels very similar. And so what we've done is between when we received the balloon in November 22 and December 23, we went on and recorded all the cases that we performed. And we were part of 3 hospitals that were part of the early adopters, so Bristol, ourselves in Bournemouth and St George's. And we all collected our data. I'm very grateful to the teams there for being part of this and helping us put this together. So I'll skip ahead and look really mainly in acute coronary syndromes because I think these are the interesting data that we've got today. So there were 274 procedures overall in this C2 Plus cohort. And of these, you can see, much like data that's been presented already, in the real world, around 50% of these are chronic coronary syndromes, and the rest are acute coronary syndromes. And 9% of this cohort were in the STEMI population. So what about outcomes in these patients? So we looked specifically at target vessel revascularization, and we compared the acute coronary syndromes with the chronic coronary syndromes. Now, of course, one of the disadvantages of our data is that our median follow-up is 180 days, so clearly we need longer-term data. But as you can see from the Kaplan-Meier curves, there's no significant difference here in terms of the target vessel revasc when comparing chronic and acute coronary syndromes. Then we wanted to particularly look at the STEMI cohort, accepting that's a smaller population, and we compared our STEMI cohort with the rest of the cohort. So that was those with chronic coronary syndromes and ACS accepting STEMI. And of course, the STEMI population is small, and again, the median follow-up is 180 days, but again, no statistical difference in this analysis. Clearly, as has already been mentioned, we need longer-term data. So I thought I'd talk a bit about what the advantages potentially of C2 Plus are. When we look at CAD3 and CAD4, the mean stent length was around 31 millimeters. And that's hardly surprising given that the inclusion criteria to be in these analyses was that you had a lesion length less than 40 millimeters. In our C2 Plus analysis, we found that the mean stent length was actually a lot higher than this, an extra 50% at 46.5 millimeters, and around 10% of the population involved complex 2-stent strategy bifurcations. So then if we look at the number of pulses that were delivered in each of these analyses in order to achieve these results, we can see that CAD3, they use 69 pulses on average, and then Disrupt CAD4, 104, whereas we were able to use 122 as a mean. And of course, what does this mean in terms of resource? Well, actually, you can see that Disrupt CAD3, they achieved the 69 mean with 1.3, and then CAD4, of course, in order to achieve 104 with a C2 balloon, you have to use more balloons, and they use 1.6. We were able to use 1.2 on average, which of course has significant resource implications for us. So I hear you saying, well, extra 40 pulses, does that increase the risk of perforation? In the previous analyses you've already seen today, low rates of perforation, and actually in our analysis, considering the lesions are probably more complex than CAD3 and CAD4, we had 2 perforations, so that's 0.7%. And actually this is consistent with all the data that we've previously seen in the recent meta-analysis, so showing 0 to 1% rates of perforation. And when we look at these weren't related to the C2 plus balloon itself. This was due at the time of post-dilatation. So what about outcomes, comparing our study with CAD3 and CAD4? We, as I say, only had median follow-up out to 180 days. And so I've presented the Kaplan-Meier adjusted mortality at 180 days, and, the target vessel revascularization at 180 days. And as you can see, similar, particularly when you consider that the lesions in our analysis were longer and likely to be more complex. Clearly, we need to do longer-term follow-up of these cohorts. So I just thought I'd talk about 2 subgroups within the C2 plus analysis, and we've already talked a bit about this. So in our population, around 10% were treatment of restenosis. And what we found was that, again, there was no difference in terms of the outcome of target vessel revascularization, which, given that the patients who come back with restenosis are the ones who are going to restenose in the future, was surprising and clearly very encouraging. I think, we need longer-term data to demonstrate a bit more. And in this analysis, in the restenosis cohort, the intracoronary imaging rates were around 90%. And actually, the overall C2 plus analysis, we were using imaging in around 88% of cases, so high imaging use. And us and other centres have published their longer-term experience of lithotripsy with in-stent, and there's a good wealth of experience now that shows that it can lead to good outcomes. And finally, I thought I'd talk a little bit about multimodality calcium modification. So we know we have lots of tools in order to modify calcium, and in particular, we've talked a bit about rotor-shock rototripsy, and in our analysis, we had 15% were either rotational atherectomy or orbital atherectomy with lithotripsy. And as a shameless plug, I'll be presenting tomorrow on our longer-term outcomes of rotor-shock in the sort of pre-C2 plus era. So if you fancy an early start, it'd be lovely to see you there. So in summary, what have we shown? Well, we know that the C2 plus balloon works well in STEMI. We've shown a case, and actually the short-term TVR rates are good. We've also shown that the C2 plus balloon allows us to treat longer lesions with less number of balloons, which of course has significant advantages. The C2 plus balloon doesn't seem to be associated with worse perforation rates, and we've demonstrated acceptingly on short-term follow-up that there's a good, durable result from these cases. Thanks very much.
So thank you. I mean, we've had 3 fantastic presentations outlining some, really important now new data supporting the use of IVL. There have been some further questions, haven't there? You've shown very nicely the role of imaging and the fact that you adopt a high level of imaging. We just have a question, which is a fair one. In the absence of imaging, actually, how do we go about sizing our IVL balloon? Alfonso, what's your thought on that?
In the absence of imaging with angio, it's not another option. So if you can do imaging, and in Spain is the same than yours. We are in 15 to 20% in real life cases using imaging. Probably in calcified lesions we are going up, but if you don't have imaging, you have to trust in angio.
So just before we take your questions, just to extend that one step further, so the 120 pulses means that we can deliver across a longer segment of calcified disease. But inherently, that might then lead to us having a discrepancy in caliber. So if it's an LAD and it's a 3.5 proximal and it's 2.5, 3.0 distal, How do we select the balloon there? Do we have to take 2 devices? Is that why we saw 1.2 devices in the UK 120 pulse data, C2 plus data?
Yeah, I mean, that's a good question. I don't know the breakdown in terms of the devices that we used. I think there's a balance, isn't there, between using more devices. I would sort of aim for a sort of middle ground, but I don't think there's a right answer there.
Yeah. So, we've got a couple of questions. Great.
You hear me?
Yeah.
Okay. Thank you for the nice presentation. When you have a relatively long lesion, calcified lesion, do you recommend to apply all the pulses in certain point or to move the balloon a little bit distal and proximal? What's your recommendation?
Yeah, I mean, I think following the data from the France Lilly registry, I'm keen to use all the pulses, but equally, if you've got a long lesion, you want to try and cover the whole lot with one balloon, being fiscally responsible. And so, yeah, I would move it up and down, but I tend to focus on the bit that is the most severe when I look at it on intracoronary imaging.
One comment about that. Taking into account the design of the device, you should overlap at least 2 millimeters because the meters are in this point. So you should overlap always the IVL balloon at least 2 millimeters to modify all the long lesion.
Thank you.
Can we get the smart screen on the big screen, please?
So yeah, just to reinforce that, the understanding, it's important to understand the nature of the balloon. So if I just get my colours right. So when you're looking at it fluoroscopically, you'll see the markers of the proximal and distal edge of the balloon. And actually, Jonathan and in Bournemouth, Peter O'Kane together very much like using stent boost. And it was beautifully demonstrated this morning, actually, where you actually get to see visualization of the emitters within the balloon itself. And so then clearly that question, which is a very pertinent one, is should you be moving? I mean, obviously, you're creating this mechanical disruption of the calcium in these arcs coming from the emitters. So shifting the balloon up a little bit, down a little bit, in theory, may well change that force within the calcified territory. So actually, it's really important to understand the mechanism and the build of the device to then think about how you'll most effectively and efficiently adapt the calcium across a long segment of disease.
We have another question, but I just really want to squeeze in one more question that came in. We saw the data for using IVL in in-stent restenosis, but what about under-expanded stents that come back and you see them?
I mean, yeah, we have experience of this. I think under-expanded stents, particularly if it's calcification, it works really well. I accept that there are theoretical concerns around the polymer, but we've used it in relatively recently implanted stents, and in our analysis, there was no difference in terms of outcomes, but it was a small analysis when it was recent or long-term recent.
Question.
Yeah, congratulations to all the speakers. So I just want to add a brief comment about in-stent application of IVL. So I was the PI of the replica study. And in the replica, we enrolled 100 patients in which IVL was applied intra-stent. So 75% of this, so 75 patients, were treated for in-stent restenosis, while 25 were treated for acute under-expanded stents. So immediate results and geographic results and 1 month clinical outcomes were the same in patients treated for IVL in-stent or for native lesions. But at 1 year follow-up, in-stent restenosis treatment with IVL was the major predictor of MACE in our population. But the clinical results in patients treated for acute stent under expansion were very good, the same that were in patients with native lesions. So I think that probably treatment of in-stent restenosis patients is a very heterogeneous group of patients, and it depends on the underlying mechanism of in-stent restenosis. But at least in our population, in-stent restenosis treatment was the stronger predictor of MACE at follow-up.
So another technical question for the panel. How safe is it to use lithotripsy at bifurcations and long tortuous lesions, tortuous vessels?
In France Lilly registry, there is no more MACE in bifurcation, and it was not a factor associated with TVF, neither in univariate analysis. So it's quite safe, and of course, the theory of that you can keep the guide wire on the side branch. However, we know that in rotational atherectomy, you don't compromise the side branch because you create a gutter, but it's something that we can take into account, keeping the guide wire using IVL. But it's not factor associated with TVF.
Coming back to the comment of the under-expanded stent application of IVL, we have conducted an experiment. We have sent to a publication. I have not the data now, but think about when you dilate with high atmospheres with a non-compliant balloon and expanded stent, probably you break the polymer more than with IVL. So we don't have the data. We have data of using IVL in an expanded stent with 2 years follow-up with no higher rate of MACE. So it's always a balance between risk and benefits, in my opinion.
So that's with respect to acute underexpansion, so having deployed a stent which then hasn't fully expanded. Okay. So, I mean, the in-stent restenosis comment from your colleague, I think, was a really important one. And you know, calcified disease is as hostile an environment as we can work within. But then to have a failed stent in either a calcified vessel where the stent has previously been underexpanded, or in now a neoatherosclerotic process where we have calcium both inside and outside the stent, to see the rates of success, both in the Spanish data and then in this smaller UK registry, I think, you know, starts to give us hope that we can give patients a durable outcome at a time when I often will go in fairly pessimistically, thinking they're bound to return. So that really is quite exciting in terms of the data that we've been shared today. Any other comments from the panel? Oh, yeah, please.
Just a comment about your cartoon there. Just want to emphasize that the impact is actually the rays going in spherical mode, and although the impact drops as the radius longitudinally is away from the emitter, you can also still get impacts proximal and distal to the emitter. And that was actually demonstrated in the case that the live case today.
Okay.
They took it right to the proximal end of the stent, and I think the dissection came from the effect of
Yeah.
longitudinal effect of the
Well, so yeah, and thank you for that comment. I mean, to extend that, I think we've spoken about imaging, we've spoken about angiographic interpretation of calcium, the need for us to treat diffuse long segments of calcium. Actually, one of the things we have to be most mindful of is that often the calcium has its highest burden actually away from what might be the angiographic stenosis, the lesion that we're focused upon by the angiogram, and where we then may place the IVL first, is often not the place you need to be doing the most work. And so again, for me, that's where imaging plays quite an important role in terms of fully understanding the extent of the vessel that's going to require modification. So I think where you can and where it's available to you, where it's reimbursed, then I think putting together the IVL with the imaging provides the greatest understanding of what we're trying to do.
Just a quick follow-up from Rashid, one of the comments, and he is just referencing a JACC paper that looked at in vitro damage to the polymer following lithotripsy, and it showed no significant damage.
So I think we're coming towards the end, and it's really grateful to you for sticking with us, but I think it has been a tremendous hour, and I've learned a lot from the data that we've had shared from these fantastic colleagues. So just to summarize that, really, I think what I've learned, I hope what we've learned, is that there is this clear association between calcium and the presentation of acute coronary syndrome, and that potentially poses problems. It can be done in the middle of the night, 6 o'clock in the morning. It can be deferred where a patient has been stabilized. We've seen from the Spanish data, that actually IVL provides an incredibly safe solution for calcium in this setting. And really impressively, in the acute phase, we see that actually it's achieving a final in-stent stenosis equivalent both in ACS and in stable patients. We have seen, though, in this larger cohort that there is undoubtedly hazard associated with acute coronary syndrome. So these patients are at risk and we need to take every care. And so having solutions that have no learning curve, that are quick and easy to deliver, help us in that mission to try and reduce patients' poor outcome. Some really interesting data from the Lilly registry, which clearly we're very grateful for the idea that Empower CAD will hopefully offer us some better understanding of how we go about protecting women who we've seen are at even greater risk in this setting. And then from Jonathan, the exciting extension of what C2 Plus now provides in terms of dealing with longer segments, higher burden calcium, and in this setting without any obvious increase in MACE due to the procedural complexity. And then beyond that, and we've had some very useful discussions about the importance of recognizing in-stent restenosis as a further subset of lesions and patients who prove very challenging for us and particularly challenging for themselves in terms of returning. So thank you. Thanks for your attention. It's been a fantastic session. Thanks to Shockwave.